Well, it's a pleasure to be here today to talk about irritable bowel syndrome or IBS and making the diagnosis. These are my disclosures today. I think the thing about IBS is in many ways, it's the ugly stepchild of GI, right? You can spend your entire career running from it, or you can be like me and choose to embrace it. But either way, you are going to see it. By the 2016 Rome 4 criteria, the prevalence across the US was 5.3%. Up or above or below that, depending on where you are elsewhere in the world. And in reality, with the upcoming Rome 5 criteria, IBS will become more prevalent again because the definition will change somewhat. But in general, I would say as a rule, about 10% of patients across the world have IBS. So you're going to see it. In the preceding 12 months, more than a half patients with IBS sought care from a primary care provider, and about half exactly sought care from a gastroenterologist. Now, what are the criteria by Rome 4? I mentioned that they likely will be changing in 2026, but this is recurrent abdominal pain with some degree of frequency, at least a day a week in the last 3 months, with some degree of chronicity, starting 6 months ago, associated with 2 or more of the following: a relationship to defecation, associated with change in frequency or the form of stool. Now here, pain is king. Discomfort is no longer part of the IBS lexicon, but as I said, I suspect it will be coming back. We did require a higher frequency of pain for a diagnosis, and as previously, you have to have an association to defecation, not necessarily improvement with defecation. And I often see people say, well, IBS should improve with defecation. Not necessarily. Wouldn't be a good GI talk without a Bristol stool chart. But Bristol stool chart, beyond just being humorous, is also a surrogate for colonic transit time, right? Shorter colonic transit time means looser stools. These are your type 6 or 7. Longer colonic transit time, more water absorbed, harder stools. These are your types 1 or 2. And this really helps us break down the subtypes of IBS. So more than 25% of looser stools, IBS-D or with diarrhea, more than 25% solid stools, IBS-C or constipation. And if you're unlucky enough to have both, more than 25% of the time you have IBS-M. Now, actually sorting out what type of IBS someone has is not always clear. I think when someone very consistently has a constipation phenotype or a diarrhea phenotype, it's very easy to sort it out. But particularly for those mixed people, what do I do? What drug do I treat them with? Because I don't want to slow them down or speed them up when they might just go the other way. And I think here a bowel diary can be helpful. Here you can see a diary of stool consistency in the blue and pain in the red. And this person will variably go from diarrhea down into constipation and back up into diarrhea. But if we look at abdominal pain, this person really has their pain associated more with the diarrhea. So if I were to prioritize treatment here, I would sort of think of them more as an IBS-D, although in reality, they do fluctuate between stool forms. Now, what about IBS versus functional diarrhea, functional constipation? They have a lot of overlapping features. There's a lot of switching among patients that may be based on the severity and the frequency of abdominal pain. So sort of with this nomogram here, you have pain on a spectrum. And if someone has constipation, but a lot of pain, it's very clear that they have IBS-C. But the next day, they may have very little pain, but still be constipated. They're more on the functional constipation side. So people can switch back and forth. I would say clinically, not necessarily for research purposes, you may not be able to distinguish them. And therefore, I wouldn't confine your treatment just to one entity or the other based on what your initial diagnosis was. Now, I think all of us who are watching know that IBS is not going to kill anyone. But many people with IBS are worried that it represents something more insidious, something more dangerous. And we did a study looking at more than 45,000 individuals with IBS in Sweden. And we found that there was no association between IBS and mortality. And similarly, there was no increased risk of mortality from cancer either. So again, not surprising, but you do wonder with some of these IBS patients, maybe something else is being missed. And these patients who had a first-time diagnosis of IBS, we can definitively say, no matter what their diagnosis ended up being, they didn't have any increased likelihood of dying, which means we can spend more time about education and actually helping people get effective treatment options. Now, IBS is not going to kill you, but it may make you want to die, right? IBS patients often do not get a confident diagnosis for up to 4 years, and it has impacts on quality of life, right? Those people with diarrhea are worried about urgency, running to the bathroom. They don't want to leave home. They sort of isolate. Those people with IBS-C are self-conscious about the way they look. avoidance of sex, some difficulty concentrating. And we know IBS of all types is associated with increased absenteeism from work or school, and really a disproportionate healthcare resource use. And this is often related to this fruitless pursuit of diagnostic testing when an IBS diagnosis should be made early on. So what sort of testing should we do in IBS? This is kind of an easy algorithm to follow. If there is any component of diarrhea in their presentation, so they have an IBS-D or an IBS-M, you should be looking for signs of colonic or GI inflammation. So a CRP, ideally a fecal calprotectin. Rule out celiac disease because it is very common for celiac to masquerade as a variety of conditions. And for those people who are older, a colonoscopy to rule out microscopic colitis can be essential. We're now seeing more and more about bile acids, more on that later. For those of you who are in Europe, you may have the CCAT test available. Here in the US, we have a serum C4, which has relatively poor performance, but it's all we have. Now, all of these things assume patients don't have any alarm features, right? New symptoms after the age of 50, blood, weight loss, anemia, all of these types of things that you all can kind of consider pretty obviously. That assumes that these patients don't have any of those when we just say we're going to do a limited workup. Now, so many patients with IBS end up getting a colonoscopy, and part of that is for, we think, reassurance. Part of it is because we're not confident in the diagnosis. This was another study we did from Sweden that looked at the relationship between risk of colon cancer and IBS diagnosis. And you can see that IBS patients actually over time had less risk of colon cancer than matched controls. The same was true for inflammatory bowel disease, although you can see most people with IBD, that is colitis or Crohn's, get it in the beginning of life. And again, controls had a higher likelihood of having IBD compared to our IBS comparators. The exception here was microscopic colitis. You can see an inflection point here where the IBS patients actually are more likely to have microscopic colitis over time. And that suggests that this is something we should think about among those patients with diarrheal type symptoms, especially where the onset or a major change in the symptoms happens, about at age 45. Those are patients that we may refer for a colonoscopy for random colon biopsies to rule out microscopic colitis. Just as an aside, you really do have to tell your performing provider that you are worried about microscopic colitis because it's not always clear that that's what's going on and they need to do those biopsies. Now, I mentioned before, bile acid diarrhea can be an issue here. And so bile is secreted by the liver, stored by the gallbladder, and then secreted into the duodenum to help solubilize fats to be broken down. If we take out the ileum, that's the site of bile acid absorption or reabsorption where it's recycled in the enterohepatic circulation, then you can have bile acids get into the colon, and that can cause diarrhea because it can cause both osmotic and stimulant effects. But we have more recently recognized that many patients with diarrhea that is mediated by bile acids actually may not have a resection of the terminal ileum. In fact, it's really that the receptors are not taking up that bile and recycling it. And so you still have the equivalent of having your ileum removed, even though everything is there and there's no evidence of inflammation. And up to 25% of patients with IBS-D may actually have bile acid diarrhea. We talked about the pathophysiology. Now, testing, the best is the CCAT test, but really there's very little availability in the US. And so we have the 7C4, not to be confused with the C4 that rheumatologists use, complement. But the test characteristics are not great. Many of us end up doing empiric trials of bile acid sequestrants. And what that looks like is either cholestyramine, which is cheapest, but probably the least palatable, cholestyramine or colesevelam. And a lot of the data that's been done in clinical trials has been using colesevelam. So that sort of is the gold standard. But because we're empirically trialing things and colesevelam can be more expensive, I tend to start with cholestyramine. If it works, then I'll switch over to colesevelam for something that is sort of more consistent or more easy for patients to tolerate during their day. Other things we could be missing. What about SIBO, small intestinal bacterial overgrowth? So many patients wear this like a scarlet letter. I have SIBO and, I really need to take care of it. The issue is that there are some patients that benefit from antibiotic treatment in IBS. I would argue it's not due to SIBO in most cases, right? In average patients who do not have anatomic abnormalities or major motility disturbances in their small intestine, SIBO is probably less relevant. And this is a study that I think confirms it, where they actually took 127 patients with GI symptoms, as well as patients who did not have GI symptoms, the healthy people. And they actually sequenced the bacteria in here. which is sort of the gold standard. And that's not what a breath test does. And what they found is that you can see healthy controls here are different in terms of the types of bacteria they have than people who are symptomatic in the blue, right? Either the solid or the open blue circles. But the SIBO positive breath test people who are in shaded blue and the negative people who are in the open circle blue here actually had no difference in their bacterial flora. So in reality, the microbiome is altered in patients who have GI symptoms. Whether that's the cause of the GI symptoms or just a marker of the symptoms is another story. But I would argue that SIBO may not be the driver here. And this is a meta-analysis showing sort of some variability in the amount of patients with IBS who have SIBO. And the overall clinical practice update that was published said that the relationships between SIBO and symptoms and those without obvious predisposing factors are more tenuous and symptoms are weakly predictive at best. So I would say we need to focus less on SIBO because in reality, there are a lot of other things that we should be thinking about, and mostly it's just going to be IBS. What about post-infection IBS? This was formerly known as post-infectious IBS, but we call it post-infection IBS now. And we know that this can occur in about 10% of patients who develop an infectious enteritis. There's been some really nice studies in unfortunate towns where their water supply has been contaminated, where they've been able to study who develops these types of symptoms. And the consensus really is the people who are at risk have a GI infection. They are female, they're younger when they get the infection. They have psychological distress at the time of the infection or just before the infection. So they are living a stressful life and then they are unlucky enough to get an infection as well. The severity of the infection, people who get very severe infections certainly can develop IBS afterward. And it seems that bacterial, more so than viral infections, are involved. And I think parasitic infections are also high risk. Now, the treatment here doesn't differ, but I like to reassure patients that there is a natural history where it may be years, but over time, patients do tend to improve on their own. Doesn't mean that we shouldn't treat these patients, but we can reassure them that they can do better over time. What other things can we miss? Well, pelvic floor dysfunction or rectal evacuation disorders, they can be seen in up to 25% of constipated patients, including IBS-C patients at the tertiary level. And history of anal rectal symptoms like straining or incomplete evacuation don't actually tell us whether patients have this or not. And as a reminder, your rectum normally has this angle, which is maintained by the puborectalis. Your external and internal anal sphincters are contracted. And then as you bear down to have a bowel movement, the anal rectal angle straightens out, the internal, external anal sphincters relax, and it's like pushing someone you don't like out the room. You give them a good push, the door opens. If that door doesn't open, because this sort of symphony of muscles and nerves does not happen appropriately, then you can be pushing against a closed door. And that can be very effectively treated with pelvic floor physical therapy and diagnosed by a test called an anal rectal manometry that's beyond the scope of this talk today. Now, we've talked about a few things that you can miss in IBS, but a lot of it is we're not missing anything. And so a patient experiences here at the top symptoms that makes them feel rotten, right? They have urgent visits tests, and we are focused on organic disease. What do we rule out? And we send them for tests. They may have unnecessary surgeries, which we know is the case in IBS, like cholecystectomies, appendectomies, et cetera. They don't get any better, right? Because we're not treating the underlying IBS. They start to get hypervigilant toward their symptoms. They have anxiety about their symptoms. And then the cycle starts anew because those symptoms have them presenting back to you. And you, again, are looking for things when in reality, you should be just making the IBS diagnosis. So how do we understand this diagnosis? I think it's best understood through the lens of the brain-gut axis. And I think it's important that we talk about the elephant in the room here, because I think one of the reasons IBS is maybe poorly thought of in GI circles is that we do see a lot of psychiatric overlap in patients with IBS who are coming to see a gastroenterologist. We know that anxiety or anxiety disorders can worsen or even trigger IBS symptoms. And probably it's fair to say that vulnerability to anxiety, depression, neuroses do tend to track with vulnerability to IBS. And we know with women with IBS are much more likely to have a history of childhood abuse. And likely what happens is early life traumas can lead to hypervigilance by changing the brain-gut axis, right? The brain-gut axis is developing all the way up into the 20s. And now during that time period, you have an insult, any type of insult, a sexual assault, neglect, abandonment, all of these types of things. And now that brain-gut axis that is growing and developing grows in a maladaptive way. Um, this was a really interesting study that looked at the overlap in genetics between anxiety, neuroticism, depressive symptoms, and patients with IBS. And what they found is that even among those patients who only had psychiatric disease alone, or only had IBS alone, that they still shared many of the same genetic changes. And so really it sounds like that these patients, as I mentioned before, have a shared susceptibility, right? They are wired for both these types of psychiatric diseases and wired for IBS. That does not mean that the IBS is a result of their psychiatric symptoms. And so I think that's an important nuance when you're thinking about these patients, is that they still merit treatment for IBS. You can't just say, well, this is just related to your mood disorder. Unless the patient really has an overwhelming depression and that really should be treated up front, or anxiety, more of this is related to kind of a shared common wiring. And this all reminds us that motility, which we tend to focus on in GI, right? Constipation, diarrhea, is only one aspect of this complex biopsychosocial model. There are biologic factors like motility, inflammation, food, diet, but there are also psychosocial factors, early life factors. All of these kind of give us our outcome, which is an FGID, or a disorder of gut-brain interaction. We can't just focus on one and expect to be a cure-all for many of our patients. And just as a reminder, I want to talk about this pathophysiology in the brain-gut axis. So imagine you're inflating a test balloon in some poor individual, right? You're stretching out their sigmoid colon. In IBS, these signals are amplified here at the peripheral level, sent along to the spinal cord, maybe amplified here in the spinal cord, and then sent up into the brain, where it can be amplified along several levels, including some areas that are involved with emotional processing. Only then does it reach the primary somatosensory cortex, and we're able to say, I feel something from my stomach. Now it's had an opportunity to be amplified all along the way. What's less recognized is that these symptoms that are being amplified here in the periphery can actually be blunted by our own built-in system here. And so we have descending pathways that are noradrenergic, serotonergic, opioid pathways that can actually blunt these abnormal signals as they're coming up to try and reach consciousness. And so that gives you a sense as to why we might use drugs that have impacts on these pathways when we're looking to treat IBS, like tricyclic antidepressants, for example. But it also tells us that when we're under stress, our brain is otherwise preoccupied. We may not be able to use those brain pathways to help go down these and blunt these abnormal signals that are coming up from our gut. And I think that can be helpful to explain to patients, to say stress is not the cause of your symptoms, right? Many of us have stress who do not have IBS, but stress can be the volume control that may amplify how much your signals affect you at a given time period. What about beyond stool form? We talked about IBS-C, IBS-D, IBS-M. This was a latent class analysis from a group in the UK that took a good chunk of over 700 patients with IBS diagnosed by the most recent criteria, and used a latent class analysis, which is just a way of looking at sort of groups of traits where people will kind of fall together that may not be what you expect. And they came up with 7 clusters. And you can see the clusters have varying degrees of GI symptom severity, psychological burden, diarrhea, constipation, etc. Most importantly here is not knowing who's in these clusters per se, but the fact is that those clusters with GI symptoms and high psychological burden were all associated with decreased healthcare quality of life, more healthcare resource utilization, more absenteeism, and more activity impairment. So the psychology here is very relevant. These are the patients that are probably most likely to show up in your clinic, and they're the ones who have the biggest impact of IBS on their quality of life. And in these clusters, these patients, if they were to have a cure, many of them would be willing to accept the 3 to 5% risk of death. Now, I think none of us in this field want to, prescribe a drug or do something that results in a 3 or 5 out of 100 chance of your patient dying. But I think it shows you how much these symptoms affect their quality of life and why we shouldn't dismiss them and say, well, it's just IBS. You don't need to worry about anything bad. Well, it's just IBS. It's not going to kill you, but it's going to make you miserable, and it does deserve treatment. So how do we think about the brain-gut axis, and how do we put it into focus based on the way patients present to us, right? How can we kind of use this nuance to help them understand what their diagnosis is? So the patient says, I just know it's something I'm eating. And food has become, and diet has become an amazing tool for our patients to take control of their IBS. But I would argue that there's a more nuanced view here. It's not that food is the problem per se, it's your response to food. And I think this study is nice, a representative of that phenomenon. So this group in the UK took patients who had IBS here in the top graph and those who were healthy volunteers and gave them inulin. And inulin is a FODMAP. You all know the high FODMAP that all of us ferment into gas. And you can see over time that patients develop symptoms while taking in the inulin, whereas those people who were volunteers didn't have any symptoms. Well, what was really cool about this study is that they paired these symptom responses with measurements of the amount of gas in the colon to say, well, maybe the FODMAPs are getting fermented and it's stretching people out, and that's what's going on. But interestingly, you can see here that the patients in the top had significant worsening of their colonic gas, right? They produced more gas in response to these foods, but so did the volunteers, right? There really wasn't much difference in gas production. And what that tells me is that it's not the fact that these foods provoke gas production. They certainly do. It's the fact that some patients respond to them and some don't. And that is likely a matter of nerves and sensitivity. Part two of this, though, is that the science here is evolving. This was a study from a couple years ago now where 108 patients with IBS received 4 common kind of trigger foods: wheat, milk, soy, egg, and yeast. That should be 5 trigger foods. And this was done via an endoscopic catheter and then using confocal laser endomicroscopy, which is a way of looking through a scope very clearly at cell junctions. 70% actually had a reaction to these foods when the foods were placed directly on duodenal cells, meaning the duodenal cells reacted primarily to wheat. And those patients were more likely to have also other symptoms or other allergy conditions, atopic conditions, compared with controls. And this was associated with changes in eosinophil degranulation and expressibility of permeability proteins. So after all, there is something to this leaky gut idea, right? Some foods may actually cause the cells in our duodenum to spread apart. That allows these food antigens to get between the cells and maybe stimulate the nervous system and cause symptoms. So the science here is evolving. It's not ready for prime time, but it certainly has some really nice pictures. And you can see as food is applied, that these cells here are spreading apart and these gaps are getting larger and larger, right? So this is the real-time view of what's happening. So you can see it's playing over again. The cells are nice and tight together. You apply this antigen food, let's say wheat, and now the cells are spreading apart, allowing those antigens to now get deeper into our gut or deeper into the layer below the gut and trigger nervous system responses. What about dysbiosis? Well, you know, as a microbiome researcher myself, I have no idea what the ideal microbiome looks like besides the fact that it's diverse. But what we do know from the microbiome is that the microbiome itself interacts with nerves. And so now we're thinking of this brain-gut axis is that the microbiome can trigger nervous system engagement by a variety of methods, right? It can use enteroendocrine cells to stimulate serotonin release, which then circulates through the body and affects the brain. It can stimulate the immune system, which secretes cytokines that circulate through the body. Bacterial molecules can get through that leaky barrier that I showed you and may be circulating in the blood and having impact on the central nervous system, the brain. And then there are nerve projections that come into the gut that can be sensitive to what's happening in the gut, but they themselves can influence the gut. So a nerve may release something like noradrenaline that can actually change the way the gut works. So the gut can be a catalyst for change in how we sense, and that the bacteria in the gut, I should say, can change how we sense, but we can also affect the gut microbial composition. And that may mean that, that what we see as dysbiosis or certain diagnoses that are bacteria related could just be a marker of IBS, or what I think more likely is that they are both a marker of IBS and may play some role in the pathophysiology of IBS as well. I know my symptoms you know, I know the symptoms are worse with stress, but what's really going on here? So what happens to a patient, you know, when they show up to a party and they have IBS, right? So they feel some rumbling in our stomach, right? All of us have our whole GI tract peristalsing at this very moment, and yet we are not aware of it. Maybe some of you are aware of it now because I mentioned it, but they feel the rumble. Most of us would ignore that. When you have this hypervigilant nervous system, now your brain is saying, uh-oh, it's going to happen. Something's going to happen. What was that? Here it goes. But they're just hungry. Okay, now there's anxiety that's specific to GI. The rumbling's bad, right? Rumbling means things are moving too fast. I'm going to have to go to the bathroom. There isn't one in sight. It's really going to be embarrassing. And then we have behaviors out of proportion to symptoms. I just have to get out of here, right? They haven't had diarrhea yet, but they're leaving in advance because they've been patterned to know that symptoms are going to get worse. And so we have to treat both the symptoms, but we also have to treat this underlying GI specific anxiety and the behaviors that have outer proportion to symptoms, in addition to the enhanced perceptual response of normal sensations. And this speaks to a multidisciplinary approach that may integrate medical therapy, in addition to cognitive behavioral therapy and dietary therapy, all so that we can avoid this particular scenario. So when I see a patient with IBS, I always wonder to myself, what type of IBS patient am I seeing today? You know, at MGH and many tertiary hospitals, we see people from the community who've never seen a GI doctor before. We see people who have seen 5 or more GI doctors before. And those patients actually reflect different groups. So if we think of a stoplight system, the mild people, who are the most common, primarily have bowel dysfunction. They don't have a lot of psychological or psychosocial distress. They tend to be older. They tend to be relatively balanced between men and women. They don't have a lot of healthcare resource utilization, other symptoms that are non-GI, and they are very often working. Many of the patients that show up in GI, though, are moderate, right? They have a mix of bowel dysfunction and pain dysregulation, right? This brain-gut axis phenomenon. They're now having more psychological and psychosocial distress. They're higher likelihood of being female. They're now mixed between old and young, and they're starting to have an impact on healthcare-related quality of life. Other somatic symptoms impact on ability to work. And then these tertiary level patients who show up primarily with CNS pain dysregulation, they have a lot of psychosocial distress, catastrophizing, a history of trauma like we talked about. This is much more so a young female group than the other groups. And they have a lot of comorbid other somatic conditions, for example, fibromyalgia, interstitial cystitis, chronic pelvic pain. Their health-related quality of life is quite poor. They use a lot of healthcare. They have a lot of activity restriction, and they are often disabled to some degree or another. I think one important thing about making a diagnosis of IBS and then effectively treating IBS is sort of understanding this disorder of brain-gut interaction. So how do I tell my patients? Well, first I explain the idea of visceral hypersensitivity. That is, normal gut sensations are inappropriately amplified in the periphery, right, at the level of the intestines, and then along the way up to the central nervous system. Okay, so it can happen anywhere in all of these pathways. These signals are upregulated, and you have an abnormal sensory response to normal physiology, right? This gut here is just moving, it's peristalsing, but the nerves are picking up something far different, and your brain is getting signals that are saying, help me, SOS. So you have this abnormal sensory response to normal physiologic processes. And for our sick patients, right, the red lights that I showed you on the previous graph, treatment is a 3-legged stool. Why 3 legs? Well, if you take one way, it falls over. We start with motility agents, right? We speed people up, we slow them down. But I think all of us can usually make someone go to the bathroom or stop going to the bathroom. We can think about dietary changes. This is important because patients are requesting this information. They want to take things into their own hands. And then we can leverage the brain-gut connection by using either neuromodulators, off-label uses of antidepressants such as tricyclics specifically, or other brain-gut behavioral therapies like cognitive behavioral therapy or gut hypnotherapy. I think IBS is a really interesting disease that often many people run away from, as I mentioned at the beginning of this talk. And IBS is one of the few conditions where your patient's perception of the doctor's interest and concern for them is an independent predictor of success. And so by showing time up front, understanding, having them feel heard, these patients can actually do much better than if they feel dismissed and unheard, because they'll either go to another doctor, which you may or may not want, or more likely they're going to come back again and again because they haven't really gotten a good understanding of what's going on. So with that, I want to thank you and look forward to the upcoming questions.